Welcome, everyone. Thanks so much for joining us today for this ISHLT IC-OS webinar. We're expecting quite a few more folks, so hopefully they'll trickle in soon. So I'm Richard Chang here at the University of Washington, and I want to thank ISHLT and IC-OS for hosting this webinar as a joint effort between the societies. It's very exciting to see the fields collaborating for advanced heart failure and cardio-oncology because there's quite a bit of overlap. Today, we have the privilege of talking about cardio-oncology after heart transplant, as well as durable LVAD. With the aging population worldwide, cancer is becoming more prevalent. Because of improved cancer treatments, we know that these patients survive their cancer only to develop cardiovascular disease downstream. The question becomes, for patients who have advanced heart failure, when can we consider durable LVAD or heart transplant, and how do we manage them afterwards? Rather than providing a comprehensive overview, we decided to focus on a few key challenging issues today. First, for heart transplant recipients, is immunotherapy an option? For example, melanoma is very common and immune checkpoint inhibitors are frequently used, but this directly opposes the immunosuppression pathway. So Dr. Yael Peled, who is a director of heart failure and transplant Sheba Medical Center, will be talking about this. Second, when can we consider durable LVAD in patients with cancer? There are specific concerns for bleeding and thrombosis and the need for cancer treatments while on MCS. So Dr. Farouk Sheikh, who is the medical director of advanced heart failure at MedStar in Washington, D.C., will be talking to us about this. We also have two wonderful panelists, which will enrich our discussions. Dr. Darini Ramu, the director of Cardio-OB at the University of Minnesota, and Dr. Margot Davis, the director of cardio-oncology at the University of British Columbia, will be joining us for the panel discussions. So with that said, I will hand this over to Yael for her talk.
Thank you, Richard. I'll share my slides. Okay, hello everyone. I would like first to thank the Society. It is such a privilege to share the stage with such talented speakers, and I look forward to learning from each of you today. So the use of immunotherapy in heart transplant recipients presents a complex challenge. It involves intricate interactions between the patient's immune system, the transplanted organ, and how these therapies affect immune responses. A key difficulty lies in balancing the need to prevent organ rejection with the goal of managing cancer progression. The ancient Indian parable of the blind man and the elephant serves as a useful analogy. In the context of cancer immunotherapy, failing to integrate all relevant data can lead to incomplete insights and suboptimal treatment strategies. Through a real-world case presentation, I aim today to highlight key considerations in the care of transplant recipients undergoing cancer therapy. Cancer cells have evolved to evade immune surveillance by activating checkpoints which serve as physiological retro-control mechanism that regulates immune cells to distinguish between self and foreign cell. While insufficient regulations can lead to autoimmunity, excessive expression of immune checkpoint results in hyperresponsiveness. So cancer cells evade immune surveillance by expressing ligands for immune checkpoint molecules on their surface, which increase negative signals. As a result, T cell activation is inhibited, disrupting the body's anti-tumor T cell responses. Conversely, immunotherapy can harness the immune system to fight cancer. Broadly speaking, immune checkpoint inhibitors are monoclonal antibodies that inhibit immune checkpoint receptor expressed on T cells from binding to their ligands, thereby enabling persistent T cell activation and proliferation. The immune checkpoint pathways that are currently targeted include the programmed cell death protein 1 and its ligand PD-L1 axis, the cytotoxic T lymphocyte antigen 4 pathway and its ligand CD80, CD86, and the lymphocyte activation Gen 3 pathway. So the use of checkpoint inhibitors in transplant patients represents two main challenges. First, through the activation of effector T cells, the checkpoint inhibitors can not only reduce tumor burden, but also increase the risk of graft rejection. And second, the use of immunosuppressant can compromise the anti-tumor activity of immunotherapy. Consequently, clinical trials often exclude transplant recipients due to concern of graft rejection, resulting in limited knowledge of the safety and efficacy of potential life-saving therapy for our high-risk patients who face increased cancer-associated mortality. So when evaluating new therapeutics, it is important to weigh the benefits against the risks. We present the case of a 67-year-old male who is 2 years post-heart transplantation due to ischemic cardiomyopathy. His medical history includes dyslipidemia and mild interstitial pulmonary disease. His maintenance immunosuppression regimen consists of mycophenolate mofetil at 500 milligrams twice daily, PRED at 5 milligrams daily, and tacrolimus. Notably, tacrolimus was replaced by everolimus 1 year post-transplant due to declining renal function. The patient's graft function remains stable, and he has not experienced any rejection episodes, maintaining a baseline ejection fraction of 60% and no DSAs. 2 years following his transplantation, he was diagnosed with stage 3A squamous non-small cell lung cancer, characterized by a mass near the right hilar lymph nodes at station 4R. Molecular analysis identified mutation in the PTEN, FBXW7, and TP53 with undetermined PD-L1 status. For first-line treatment, the patient was administered a combination of carboplatin and paclitaxel alongside concurrent radiation therapy up to 60 gray, achieving a partial response after 6 cycles. Surgical interventions was evaluated but deemed high risk, thus contraindicated. Initially, durvalumab maintenance therapy was withheld due to concern regarding potential graft rejection. What are the associated risks? Durvalumab is a checkpoint inhibitor that targets PD-L1. These slides prompt us to explore several important questions. What are the risk factors contributing to immunotherapy-induced allograft rejection? What are the underlying mechanisms and phenotypes of rejection? What outcomes can we expect for immunotherapy-induced allograft rejection? What is the most effective treatment strategy for transplant patients experiencing graft dysfunction? And additionally, what is the risk of non-graft immune-related adverse events? By addressing these questions, we can gain a clearer understanding of the implications and management strategies related to immunotherapy in transplant patients. Our understanding regarding the risk of rejection has been evolving. Initially, rejection risk was reported in up to 50% of cases. This estimation was based on the results of retrospective studies published up until 2021, 3 of which are shown in this slide. More recently, small prospective trials have reported lower rates of rejection ranging from 0 to 12%. 3 studies on kidney transplant recipients undergoing immune checkpoint inhibitor therapy are presented in this slide. Only 14 cases of heart transplant recipients treated with checkpoint inhibitors have been published to date. Among these, 6 cases were confirmed as biopsy-proven rejections occurring within 3 months of starting immune checkpoint inhibitors. This results in a rejection rate of 43% for heart transplant recipients. What are the risk factors for ICI allograft rejection? Reduction in baseline immune suppression is a risk. The maintenance of at least 2 immunosuppressive drugs at the time of ICI initiation reduced the risk of rejection. Let's revisit our patient's case. As we constructed thoughtful treatment strategy, we employed a comprehensive multidisciplinary assessment and decision-making approach, consulting with our experts in oncology, transplantation, and ethics to ensure all aspects are considered. After evaluating the available options, we determined that durvalumab presents the best chance for achieving a durable response. We engaged in through discussion regarding the risk associated with ICI-related allograft rejection. Ultimately, our patient expressed a strong preference for our prioritizing cancer control and accepted the associated risk. Our plan is to initiate durvalumab while maintaining close transplant surveillance to monitor the patient's progress. The baseline echo showed an EF of 60% and normal RV function, and both troponin I and pro-BNP levels are within the normal range. Notably, DSA are negative. We will also closely monitor everolimus trough levels as we move forward with this carefully constructed approach. Together, we will navigate this important journey in the best interest of our patient health. How can we effectively reduce the likelihood of facing rejection in our endeavor? Prospective evidence suggests that maintaining patients' baseline immunosuppression reduces the risk of rejection, as demonstrated in a study enrolling 17 kidney transplant recipients who continued their baseline maintenance immunosuppression through checkpoint inhibitor therapy. 70% of patients in this study had maintenance immunosuppressive regimen that included the CNI. 2 cases of acute rejection were reported. That is a 12% rejection rate. It should be noted that the study excluded patients with immunological risk. The use of mTOR inhibitor as maintenance immunosuppression has been associated with decreased rejection. In a multi-center study of kidney transplant recipients treated with checkpoint inhibitors for cutaneous squamous cell carcinoma, a rejection-free graft survival was longer in patients treated with an mTOR inhibitor than in those without an mTOR inhibitor. The benefit of mTOR inhibitor is further supported by the absence of rejection in the prospective Contract 1 study. 12 kidney transplant recipients with advanced cutaneous squamous cell carcinoma received the PD-1 inhibitor while maintained on mTOR inhibitors and a dynamic prednisone mini pulse with each treatment cycle. They reported no rejection episodes at a median follow-up of 6 months. The study did not exclude patients based on immunological risk. A dynamic prednisone strategy appeared to confer protective effect. However, a low-dose prednisone may prove inadequate in preventing organ rejection. In a prospective study involving 8 kidney transplant recipients, participants received either PD-1 inhibitor monotherapy or combination therapy. The maintenance immunosuppression protocol comprised tacrolimus with target trough levels of 2 to 5 nanogram per ml and a daily prednisone dose of 5 milligrams. Among the 8 evaluable patients, 3 exhibited biopsy-confirmed allograft rejection, representing a rejection rate of 40%. This finding indicates that the tacrolimus trough levels of 2 to 5 nanogram per ml combined with a daily prednisone dose of 5 milligrams may be insufficient to prevent organ rejection. Other risk factors for ICI-associated allograft rejection suggested by retrospective data include prior history of allograft rejection, anti-PD-1 therapy or dual ICI therapy, low-dose steroids, and a shorter time between transplant and cancer diagnosis. A protective effect of CNI use was demonstrated. Rejection occurred early after ICI initiation with a median time to rejection of 3 weeks, encouraging the frequent monitoring of rejection during the time period. The mortality rate due to transplant rejection following ICI treatment was reported in approximately 50% of patients. Liver and heart allograft rejection resulted in higher death rate than kidney transplant rejection. Dialysis can be used for kidney transplant recipients after graft rejection with ICI and perhaps explain the lower fatality rate in these patients compared to that in liver or heart transplant patients after allograft rejection. In November 2021, local recurrence was identified as right peribronchial lymphadenopathy. The patient initiated a second-line treatment plan that included weekly carboplatin and 50-gray radiation, followed by the range reduction of durvalumab. 7 months to the immunotherapy regimen, a slight elevation in troponin levels led to endomyocardial biopsy, which indicated ISHLT2R cellular rejection. Yet the patient exhibited no clinical symptoms or elevated BNP levels. It is important to note that everolimus was discontinued due to proteinuria 3 weeks prior to the rejection episode, and tacrolimus was subsequently started, which may have influenced the rejection. The patient was administered high-dose prednisone, remained asymptomatic with normal graft function, and the rejection was resolved in the follow-up biopsy. Everolimus was successfully range reduced, and durvalumab continued after careful assessment. So what advantages does immunotherapy offer for patients with heart transplant? The initial hypothesis that immunotherapy is less effective in immunosuppressed solid organ transplant recipients has been challenged by results from 2 small prospective trials reporting objective response rate of about 50% in kidney transplant recipients, similar to those seen in the general population. Retrospective data also demonstrate that ICIs retain significant anti-cancer activity in the solid organ transplant population, with an objective response occurring in up to 50% of patients. ICI therapy for cutaneous squamous cell carcinoma, the most common cancer among solid organ transplant recipients, was associated with objective response rate of approximately 70%, better than those of other cancers, and compared favorably to benchmark objective response rate collected in non-solid organ transplant recipients. The theory of tumor immune editing provides a potential explanation for the similar response rate in immunosuppressed and in immune intact patients. The immune editing theory refers to the process by which an intact immune system selects for the survival of less immunogenic cancer cells. An impaired immune system selects for the survival of more immunogenic cancer cells, potentially rendering them more responsive to immunotherapy. Special consideration regarding tumor response exists. A literature review of 94 kidney transplant recipients on ICI demonstrated a worse tumor response rate for CNIs versus mTOR inhibitors maintenance immunosuppression, emphasizing the benefit of a transition to mTOR inhibitor whenever feasible. There is mechanistic evidence suggesting that mTOR inhibitor can promote the maintenance of anti-tumor effects of ICI therapy while allowing for the preservation of allograft tolerance. Using peripheral blood immunophenotyping, it was demonstrated that concurrent administration of anti-PD-1 therapy and mTOR inhibitor in kidney transplant recipients with melanoma led to tolerogenic changes, including suppression of global T-cell activation and preservation of the regulatory T-cell population while maintaining the circulatory levels of a subset of tumor-directed T-cells. In August 2022, the patient experienced disease progression with an increase in necrotic lymph nodes, deteriorating bronchial fistula, and tumor extension to station 7 and the superior vena cava. The third-line treatment plan included 3 cycles of carboplatin and paclitaxel, followed by 4 cycles of nivolumab, a PD-1 inhibitor. The patient's course was complicated by multiple hospitalization for severe viral pneumonia and progressive respiratory failure. In total, the patient received 20 cycles of immune checkpoint inhibitor therapy. Remarkably, there was only 1 episode of grade 2 cellular rejection, which was managed effectively through immunosuppression adjustment. Serial echocardiographic assessment demonstrated preserved ejection fraction throughout the course of immunotherapy. Sadly, the patient ultimately succumbed to infectious complications in February 2023, achieving a commendable survival of 3.5 years following their diagnosis. This case highlights the complexities involved in managing advanced disease and the importance of ongoing monitoring and adjustment in treatment strategies. So back to our starting point, making sure we get all the facts, then an elephant is an elephant. So let us recap. Before starting checkpoint inhibitors, it is crucial to optimize immunosuppression to improve response and prevent allograft rejection. This optimization should be tailored to the individual based on their immunological risk and conducted in collaboration with the oncology team. Conversion to mTOR inhibitor is encouraged. The combination partner should be guided by the immunological risk. Low-dose corticosteroids are suggested in low immunological risk, while those at high immunologic risk may benefit from combination with low-dose CNI. There are clinical scenarios in which transition to mTOR inhibitor is either not tolerated or not feasible. In these cases, the available data indicate that it is appropriate to continue the patients on the previous maintenance immunosuppression. Another option to consider dual maintenance immunosuppression with prednisone at 10 milligrams daily, along with tacrolimus targeting at trough levels of above 5 to 7 nanogram per ml. And during treatment with checkpoint inhibitors, transplant patients should be closely monitored in collaboration with transplant specialists for early signs of rejection, particularly in the first 3 weeks of treatment. Close monitoring of graft function and donor-specific antibodies is recommended, utilizing non-invasive biomarker of rejection, and a biopsy is indicated if rejection is suspected. So I would like to summarize. Evidence suggests improved outcomes for ICI therapy in solid organ transplant patients, particularly those with skin cancer. The use of ICI should be evaluated carefully regarding prognosis, outcomes, and alternative with benefits and risk assessed on case-by-case basis. Effective immunosuppression management is crucial for ICI effectiveness. A balance must be struck between organ risk and tumor progression. Collaboration with oncologists is essential to enhance the current evidence base, and more prospective studies are indeed needed to assess rejection risk for tailored immunosuppression changes. Thank you.
Wow, no, thank you so much, Yao. That was a very amazing comprehensive overview, I think, of all the literature, but also I feel like I just learned so much from it. Question for you and for the panelists. I know you showed the proposed algorithm for immunosuppression management. I'm curious from a practical approach, how do you implement it? And then one of my other questions is, on one of the slides you showed, it suggested the use of prednisone was associated with increased risk for rejection, which seems a little bit paradoxical because in other cohorts, we do sometimes use low-dose prednisone to prevent the risk of myocarditis.
Yeah, great comments. Should I answer now, Richard, or at the end after the second presentation? It's
well, I think we have about 10 minutes.
Oh, fantastic. So regarding the prednisone dose, it's important to remember that if continued only on one immunosuppression therapy plus prednisone, the prednisone dose should be 5 milligrams and above, at least 10 milligrams. Otherwise, if you keep tocopherolone with the studies we have at the levels of 2 to 5 nanograms per ml plus pred of 5 milligrams, there was a high risk of rejection of approximately 40%. So yes, use prednisone, use a mini dose prednisone, and if you keep prednisone in plus 1 immunosuppression therapy, keep it above the dose of 5 milligrams.
That's great. Let's hear from Farouk, Dorini, and Margot. I'm curious how you guys handle these types of cases with the immunosuppression, because I know there's a lot of variability, and I'm not sure there's a clear consensus on what the optimal regimen is.
Thank you, Richard. I think, this case again highlights how important it is that we individualize this to each patient. And, even in the non-ICI cancer therapy data for transplant patients, there's data to say that using mTOR inhibitors reduces the risk of cancer, reduces the risk of cancer recurrence, and reduces mortality associated with cancer in transplant patients. Similarly, I think there's also a more recent paper in JAMA Oncology that was a systematic review looking at over 340 solid organ transplant recipients, a small percent of whom were heart transplant recipients. And again, there was convincing evidence that using mTOR inhibitors and maintenance immunosuppression, again, I think those two are the key things here, reduces risk of rejection. Although, again, it remains higher, remains substantial, but still reduces the risk of rejection in these patients. So I think, as Dr. Pellet mentioned, it really involves making sure we are set up to success by starting off with appropriate immunosuppression and risk modification the best we can before we start ICI, individualizing the immunosuppression based on the patient's known immunologic risks, their previous rejection, their previous DSAs, graft function, and so on, and also close monitoring early on during that process.
Great. How about Margot and Farouk? Do you guys do anything differently, or do you practice in a similar fashion?
I mean, I think that the most fundamental message of all of this is, as the others have said, this has to be individualized for each patient. And there are certainly patients in whom, using a checkpoint inhibitor would be, I think, extraordinarily high risk, and you really need to look at other options there. But there are patients where you think that immunologic risk is acceptable, but and you can sort of proceed with great caution. I think a lot of people are transitioning these patients to mTOR inhibitors regardless when they have malignancies, although the last time I looked at the ISHLT guidelines, they actually specifically said not to do that in non-skin cancers, but I think a lot of us do it anyways, and so we're often starting off in that place. So then it just becomes the management of the steroids. I will say that, these cases are always very nerve-wracking. But even if we back up, I find that a lot of times oncologists and surgeons, they're really reluctant to treat our patients post-transplant with anything that has potential cardiac risk, whether that's anthracyclines or surgery, even if patients have good graft function and are actually really doing really well post-transplant. So sometimes, we're not even talking about the checkpoint inhibitors, which have this, I think, enormous risk post-transplant. We're talking about, about a patient who's got normal graft function and PTLD, and they're not wanting to give the doxorubicin. And so, I think we've got so much work to do to get rid of this sort of therapeutic nihilism that I think sometimes affects our post-transplant patients. And actually, Yael, I wanted to ask you, your patient was deemed too high risk for surgical resection of the tumor. And was that because of their heart transplant history, or were there other reasons?
First, I agree with every word you said. Really, I think that your approach is so important, and this is Richard, your initiative for this webinar is so important. No, it was not. It was declined not because of his heart status, but because of his he had a mild interstitial fibrosis pre-transplant. So it was his pulmonary data who excluded him from transplant. And it's so important to give our patients the best chance they can from the oncologic aspect, because this is what killing them, not the heart. We can go long. It's cellular rejection. We can manage it. Once we diagnose it early, we can treat it. So a great follow-up and give them the best chance to live going into, and the impact extends beyond checkpoint inhibitors. Of course, it goes to CAR T therapy and all other immunotherapies. And especially there is, this week, there is a publication in the Nature regarding mRNA vaccines, which for stage 4 lung and a melanoma, a synergism effect of mRNA COVID vaccines with immunotherapy. So I think it's really promising for the future for our patients and impacts all aspects, also vaccinations and preventing vaccination preventable disease. So it extends to all aspects of our life with the advances we see in the immunotherapy today.
Great. No, I have to look at the paper now. Thank you for pointing it out. Good. So let's move on now to our second talk. So we're having Dr. Farouk Sheikh. He's going to be talking about another tough scenario. When can we consider durable MCS in patients with cancer, and how do we manage them?
Hopefully you can see my screen. Can you see my screen?
Sorry, it says, yep, now we see it. Great.
Excellent. Well, thank you, Richard, the societies, the session organizer, the webinar organizers, and all that have joined. Wow, what an amazing presentation by y'all. And I'm excited to try to do something comparable as it relates to durable LVAD therapy. And so our topic today is managing malignancy and durable LVADs. My disclosures are outlined here related to consulting with Abbott. And I just provided an overview of the talk over the next 15 minutes, which includes a very important reality, which is the changing landscape of durable LVAD therapy in 2025. This current technology is not the foundational therapies in regard to serious adverse events, and including survival. So we'll discuss that. As Richard outlined in the beginning comments, there is a shared epidemiology, which, given the reality of increasing prevalence of both heart failure and cancer, is something that we all must face and understand the reality that we will be seeing more and more patients who receive LVAD therapy who have cancer, and because they're living longer and because of their age and other comorbid conditions. While at the same time, whether we can actually use this technology to help bridge patients from a cancer diagnosis where they develop cardiomyopathy and be able to get them to long-term survival and potentially even down the road to transplant. We'll review some current data regarding outcomes of patients with LVAD therapy who have active malignancies, discuss surgical considerations, procedural considerations, anticoagulation, and obviously chemotherapy, radiation, and pharmacologic concerns, and really augment and highlight the wonderful comments that were made in the discussion just now, as well as in the introductory comments and Yael's presentation, which is regarding multidisciplinary team coordination, probably my favorite part of the shared relationship between our cardio-oncology partners, our oncologists, and then our heart failure team. What do we know about LVAD therapy? For reasons I don't understand, the screen on the top is blocking some of my slide, but I apologize. The most important point here is that the therapy today, the 2025 therapy, is not the foundational therapy, but rather a much improved one. For those obviously who are not familiar with the HeartMate-3, which I think most people on the call are, this therapy, a centrifugal flow device that is continuously magnetically levitated. It's a continuous flow device. is very robust. And as it was shown in the pivotal Momentum 3 trial, this therapy has markedly reduced the risk of hemocompatibility adverse events, specifically stroke, pump thrombosis, as well as bleeding. And shown here is long-term data, observational data from that trial, 5-year outcomes. The centrifugal flow pump is the HeartMate 3, and the axial flow pump, the predecessor device known as the HeartMate 2. You see all the accoutrements, the essential components of the HeartMate 3 shown here in this cartoon on the left. And we shouldn't forget the outflow graph, which of course sits under the sternum, which we'll mention as well. But you have the device, the drive line, the pocket controller, the batteries, and obviously the mobile power unit. But the highlight here is the marked improvement in survival at 5 years of 58% relative to 43%, which can be associated or is really related to the reduction in hemocompatibility-related adverse events. It's rare that clinical trials outcomes are matched or even surpassed by registry data, but shown here, the STS Intermax data report, annual report from 2024, highlights that actually HeartMate 3 survival at 5 years compared to the foundational devices, the HeartMate 2, and then the HVAD was actually better, and 5-year survival was 60%. And in some patients, particularly those under the age of 50, that survival may be as high as 70+%. Well, we mentioned and I'm sorry, let's see if I can get rid of that screen. Sorry about that. The bidirectional relationship between cancer and heart failure, as Richard began this session. I think these two articles really highlight that, and I want to applaud the authors for a review article in the Journal of the American College of Cardiology, Cardio-Oncology, as well as the European Heart Journal on the right. Well, on the left, the shared factors and features that result in both cardiovascular disease and cancer, demographic features, lifestyle factors, environmental issues, and comorbid conditions, none greater than the cardiometabolic features that really affect all of our societies. And then the treatments for, if you begin, sadly, with a cancer diagnosis, which can unfortunately result in the development of heart failure, or vice versa. And then there are biological features highlighted as well. But also important to recognize that our heart failure patients, for multiple features, including their comorbidities, their advanced age, they're at increased risk of cancer. A number of cancers, number one, just the incidence of cancer, particularly breast cancer, lung cancer, as well as hematologic cancer. Well, one study that aimed to try to answer and approach the question of how do LVAD recipients do with concurrent or concomitant active malignancy, and can they be treated and garner a reasonable outcome in this regard? And this work that was led by Anna Barak, cardio-oncologist, previously at MedStar, now at Innova, her colleague Alana Schlamp, a hematologist oncologist, and Richard Cheng at the University of Washington, highlights the work between MedStar and the University of Washington, where between our two databases, we were able to identify over 1,000 patients, of which 130 had some history of cancer. Now, 42 of them had received a cancer therapy with LVAD therapy, or with an LVAD, of which ultimately 22 were getting treatment at post-LVAD therapy, 16 receiving cancer therapy with an LVAD, and the LVAD was implanted in 6 other patients where the plan was to treat them with treatment on the back end of the implant. You see the oncological characteristics of these patients with active malignancy, the types of cancer, the median age, the intent of the treatment, curative, palliative, and then obviously the directed treatment shown at the bottom. And in this slide, we highlight the central features of the paper, which show one LVAD-related serious adverse events, notably thrombosis, which was no different between those patients in blue who had cancer and those who were the non-cancer comparator. And a matched cohort was developed such that for the 22 patients with cancer, 66 patients were matched for age, sex, cardiomyopathy type, the intent of the LVAD implantation, whether as bridge to transplant or as a bridge to candidacy, or finally as destination therapy, and also the Intermax profile, the severity of the illness. And the only difference of these serious events was actually a reduction in the risk of GI bleeding, which is, I think, a very central point of this paper. Shown on the right is the Kaplan-Meier survival estimate for those patients with cancer in blue and those, the non-cancer comparators, and the features that I just highlighted, which were matched. And there was no difference in survival between the two groups, recognizing that the median survival for the cancer patients was 3.5 years. Though important to note that in Cox regression models, where cancer diagnosis was assessed through a time-varying covariate, there was an increased hazard for mortality in that group. The surgical and procedural considerations that we have learned to deal with over the past 10 plus years in my time here at MedStar are outlined here. One, really outlining the goal of the cancer treatment, making sure we understand the stage, the therapeutic intent, and the cancer and oncologists taught us about multidisciplinary teams through tumor boards. Well, in the heart failure field, as you know, we have selection committees and advanced heart failure therapy evaluation committees, and we've learned to marry those two together so we can learn from each other as to what's the best thing to do. We really have to assess the severity of heart failure as well as the left ventricular assist system clinical status. And this is not a typo. The S is because I mentioned to you that the outflow graph must be considered in the assessment. And so we typically perform hemodynamic assessment via right heart catheterization. We will do functional capacity assessment, 6-minute walk test. We'll do imaging, and we must remember there may be times where when we're treating the cancer, we're going to have to disrupt or discontinue the anticoagulation. Well, we need to make sure that there is no occult thrombotic risk, such as extrinsic outflow graft obstruction and or aortic root thrombus, and certainly want to make sure that there is no increased risk of bleeding. And that assessment of bleeding and thrombosis varies continuously. And so this is an iterative process where we begin with one essential or inherent risk for the patient based on their co-risk or comorbid risk factors, the type of cancer they have, the treatment they may receive, but then that changes over time depending on the events afterwards. The multidisciplinary team engagement, we're actually this morning before the session, I was speaking to one of our surgeons, and I realized, you do all this outreach and you work with societies, that I have to do a better job with InReach because people didn't realize that HeartMate 3 survival is estimated at 5 years of 60%. And so many of our team members through our cancer center were hesitant to offer some therapy, thinking that the modern LVAD patient had limited survival. And so that affects our surgical and anesthesia approach. We really have to make sure we understand how is the right ventricle. Induction is a major risk factor for these patients when there's a drop in both afterload and a change in preload. And so we have to be prepared for that. And sometimes invasive hemodynamic monitoring at the time of the procedure is essential. Guideline mapping in collaboration with our LVAD coordinators, our radiologists is key. And port placement for chemotherapy. That's interesting in this patient population because many of our patients have ICDs or biventricular pacemakers and ICDs. We have to consider the infection risk. Some of our patients, unfortunately, have chronic kidney disease, which also increases, and even dialysis status, which increases the risk of infection. And we really have to be careful in the assessment of the vascular risk. This slide highlighting the anticoagulation management considerations really reinforces the concept in our first slide that today's LVAD therapy, the only FDA-approved pump currently is the HeartMate 3. And this device, it's part of the improvement in survival that is obviously marked both through clinical trial and registry data, can be aligned with this reality of hemocompatibility, adverse related event reduction shown in this forest plot. Marked reduction in the hazard for both device thrombosis, which the HeartMate 3 has pretty much obviated. At MedStar, in over 500 LVAD implants with the HeartMate 3, we have less than a 1% risk of a device thrombosis. Stroke risk markedly reduced, though still remains an opportunity for improvement. And the bleeding risk with just from the device itself, this fully magnetically levitated device, coupled with the withdrawal of aspirin in de novo patients based on the ARIES trial, it further reduced this risk. And so this HeartMate 3 design allows for anticoagulation interruptions without significant risk of adverse events. And obviously caveats there, every patient is different. But this has huge implications in terms of the need or the lack of need for bridging anticoagulation. And I think a very key aspect. We were really humbled by the reality that a number of our HeartMate 3 patients, because of recurrent bleeding risk, despite the marked improvements relative to other patients, some of them have to stop their anticoagulation because they've had GI bleeding. They've not been able to keep up with their adherence with the warfarin, or they've had very super therapeutic or subtherapeutic INRs. And sure, one option is to change off-label to a direct oral anticoagulant, but sometimes through shared decision-making, we hold their anticoagulation, and we have not internally, data we hope to share with the community soon, seen a marked increased risk of particularly thrombotic events in that cohort. Careful assessment of drug-to-drug interactions is key. We've learned a lot from our oncology pharmacy partners, as well as our own heart failure LVAD pharmacists about what to do, how to manage this, as we'll highlight in a couple cases here, and then close monitoring of LVAD performance through labs and log file. Chemotherapy and radiation considerations, I think we are well aware of this. certain drugs, certainly adriamycin, can affect the residual RV function, affect LV function. Many of our patients will face myelosuppression. We have to make sure we understand how we're going to manage that. What's going to be our upfront strategy? Will patients have to be admitted for monitoring? Obviously, we'll give stimulating factors. Their biologic status will change. The nutritional status, metabolic state will change, and that will affect the ability for them to take and continue to receive neurohormonal antagonist treatments, which may mean changes in their risk of heart failure exacerbation. And then another part that's been very fascinating for us is how do we educate our broader community within MedStar and across the region, both oncologists and infusion centers, about what is an LVAD alarm, what is it that you have to monitor for, what does it mean when we estimate the flow of the device, and what is, pulsatility index, et cetera. And we've demonstrated at our center, and others have published as well, that the capacity of this device, despite the fact that the software sits within the device, the pump, in the mediastinum, behind the sternum, in the pericardial space, that radiation can be given to the mediastinum in this patient with non-small cell lung cancer with great outcome and without any device malfunction. And so multidisciplinary team coordination is key. I think we could have all concluded our slides with this aspect. The team of teams, heart failure, oncology, surgery, anesthesia, palliative medicine, our LVAD coordinators, our social work team, ethics gets involved as well. We have joint conference review to really discuss our initial plan, what we will do when there are complications, and obviously always revisiting those complications and the relative benefits or risks of future treatment. Documentation of the treatment plan so everyone knows and are on the same page as to what we will do. And shared decision-making with our patients and families are key. And really, we set goals out in the beginning as to what are the goals, and if, God forbid, complications occur, what the patient and their family would want if those complications occurred. And what seems like the most extreme example would be LVAD deactivation, but we, in collaboration with our palliative medicine team, who are embedded on our heart failure service, will engage in those conversations up front so as to not make sure that we're really listening to our patients and their goals. Palliative care team engagement, I cannot stress enough, is essential. And we find this very helpful up front, even before LVAD therapy, irrespective of whether it's destination or long-term therapy and even bridge to transplant. We really involve them because they can help guide conversations. And obviously, there are tools online in terms of risk management that help patients with shared decision-making decisions. So let me conclude with a couple of cases quickly, just that really highlight some essential points. This patient, who is currently supported on HeartMate 3, had received a HeartMate 3 because of smoking, presented with anemia and hematochezia. Despite a colonoscopy only 4 years prior to this event, he had a partially obstructing tumor in the sigmoid colon. It showed invasive adenocarcinoma. He had staging, which showed no evidence of metastatic disease. Now, interestingly, in this hospitalization, at the same time, concomitant driveline infection was noted, so he had required a debridement and an antibiotic therapy. For board recommendation was to proceed with robotic-assisted left hemicolectomy after we controlled the infection, which we were able to do. And then eventually underwent surgery. Urology was involved to make sure we protected the ureter. And our LVAD team was involved to make sure the coordinators could be present to assist in the perioperative period with anesthesia, or invasive hemodynamic monitoring to make sure we didn't run into cardiac output or index problems, as well as filling pressure issues. And the patient actually was found to have T3N1B disease. He made it through surgery, did very well. We had to interrupt anticoagulation for an extended period of time, and eventually recommended to go through adjuvant chemotherapy, which he completed 6 cycles. And he is now 1 year post that therapy and is negative for evidence of recurrence. But the shared lessons here were, 1, it was possible for us to pursue robotic strategies to reduce the morbidity. 2, that really the key was for all of us to get together in the room to really map this out, no pun intended. And number 3 was clearly putting the patient at the center, set the goals. We are working and hoping that he will quit smoking, so one day we will be able to offer transplant in the future. Another case I think that has been exciting is this concept of myocardial recovery, and I see some of the Utah team members are on this call, and the VADWEEN registry deserves mention. Incredible work that people around the world have done in terms of approaching this concept. Well, the 65-year-old woman with a history of diffuse large B-cell lymphoma came to visit with us at MedStar, and she had received R-CHOP and treatment of lymphoma, unfortunately developed cardiotoxicity and developed end-stage heart failure. Not eligible for transplant, 1, because she was only 3 years post less than 3 years post-treatment, and 2, she was still an active smoker. And what was amazing was, despite the first few years of us pushing neurohormonal antagonist treatment and not seeing any evidence of myocardial recovery, for reasons that are unclear to me, other than maybe the extended period away from chemotherapy, year 3 or 4 after implantation, so 7 years after the initiation of chemotherapy, the patient displayed signs of myocardial recovery with favorable hemodynamics on LVAD ramp study, and now is undergoing evaluation for decommissioning and potentially heart transplantation. She's quit smoking. And this is a wonderful review article that helps highlight this. And this patient population is really prime potentially for us to identify patients with cancer who receive chemotherapy who might benefit and garner benefit from LVAD therapy as a bridge to recovery and or potentially down the road heart transplant. I conclude this slide. I skipped it with one of our real amazing stories. This 33-year-old woman who we met in end of 2023 came crashing to us from an outside hospital in a atrial arrhythmia, supraventricular tachycardia. She had been receiving treatment for AML, which involved adriamycin-based strategy. She developed severe biventricular dysfunction, required temporary mechanical devices. And in this setting, we were left with a very difficult decision because she was only months after AML treatment. She had completed her treatment, had a wonderful bone marrow response. The eventual goal was for stem cell transplantation, but there were some features that suggested maybe not complete remission. There was maybe slight risk of relapse. But we made the decision to pursue HeartMate-3 implantation on the left, HeartMate-3 implantation on the right with right atrial cannulation to be able to monitor on this therapy. And this picture comes from her traveling to Mexico within the first year of her HeartMate-6, as we outlined here. And we are excited to, because of collaboration with other institutions, they were able to shorten the window of observation to allow for transplant that she is now almost at 1 year post-transplant doing very well. Again, highlights the capacity of this technology to provide great outcomes for our patients. And so with that, I will stop and thank you again for the opportunity to speak today.
Thank you so much, Farouk. That's such an amazing presentation. Really puts into perspective, related benefit of MCS. I'm curious, so you presented a couple cases. One of them was, cancer after VAD. The other was like a individual who, has a history of, I guess, cardiomyopathy. They'll support it with a VAD for a period of time. What about the use of MCS in the patient with active cancer as a bridge to cancer treatment? I'm curious to get your thoughts and the thoughts of others on the panel.
Yeah, as I think Margot and others said in the previous discussion, it's case by case, assessment. So we will provide and utilize the same risk stratification as we do for all LVAD recipients, which is one, what is the expected, from your comorbid conditions, what is the expected survival that one could garner? In other words, if we are engage with our oncologists and say, okay, what can we expect in terms of if we were able to give state-of-the-art treatment for the malignancy, what could we expect in terms of the outcome, number one? Number two, what is the residual risk with LVAD therapy in regard to RV failure, the other end organs? That's going to be very important. And the reality has been the more we've pushed the envelope in this regard, we've been surprised. It hasn't been perfect. We've sadly lost some patients. But again, through shared decision-making, if in agreement with the patient and family that they're willing to take that risk, we have been willing to push the envelope. Recognizing there are some situations, particularly I think RV failure is a major problem in this field. We were able, because in this patient where we highlighted biventricular support with a durable device, that a partner institution was willing to shorten the period of observation to get that patient to a transplant, that we were able to work in collaboration with that center. Not all programs will be able to do that. And so with that, I would say simply, I think we are underutilizing this technology to be able to provide that therapy. And I think our risk stratification, we've learned through STS Intermax that psychosocial status doesn't matter, race doesn't matter, sex doesn't matter. The outcomes are great. The most recent reports highlight this. Even patients with advanced age are having better outcomes with LVAD therapy. And so it is time for us to consider disease states like cancer, chronic kidney disease, to be able to push the envelope.
Thoughts from the other panels?
I think specific to your question, Richard, I think one of the great strengths of the LVAD is the ability to use it in patients where there's either a recently diagnosed malignancy that you think is treatable, to Farouk's point, where if you think there could be a good cancer outcome with good treatment, or where there's even diagnostic uncertainty that would require further, like biopsy or something that the patient is too unstable to undergo, right? These are patients who without LVAD technology would just be turned down for transplant. But we've had many patients who something has shown up during the workup for transplant where we say we're not comfortable going ahead and transplanting this patient. But with LVAD, you can further investigate it. You can offer treatment with that hemodynamic support. You can be able to offer treatments that you might not be able to give somebody who's early post-transplant, whether that's immunotherapy or what. And so, I mean, I think this is such a great role for the LVAD is in the patient with recently diagnosed or concerning findings suggestive of malignancy.
What Margot jogged my memory. One comment I wanted to add is what also is fascinating is, as Richard, you highlighted this in your introductory comments, the treatments for both heart failure and oncology are improving. And this really recently struck me personally because my mother is actively fighting cancer right now, and watching her go through treatment, how incredible the therapies are from what I remember during my training, and just it's an incredible reality. There are diseases that we were not comfortable treating at our center, smoldering myeloma with some features, which now with new technologies like daratumumab, we are able to support patients potentially with HeartMate 3 device therapy, treat their underlying hematologic disease, and maybe get them to a different place, which was really not possible 5-8 years ago. And so, the next 5 to 10 years will be fascinating to consider what might be an absolute contraindication 2-3 years ago, even presently today, which will no longer be a contraindication, one for the therapy, but number two, for long-term cardiac transplantation as well.
I think I agree with everything that's been said. And, a few other things is a lot of the data looking at LVAD use in patients with previous chemotherapy-associated cardiomyopathy came from older Intermax registries, predominantly HeartMate 2 data. And as Farouk mentioned, we are in a different era of LVAD therapy now, with ability to get away from no or reduced anticoagulation and so on. So, I think this is all very doable for the right patient. Again, it is an individualized approach, but definitely an option and worth considering for the right patient.
Right. And then Yael, how do you guys practice over in Israel?
I absolutely agree. This field is just to let you know, our surgeon just finishing an operation for implanting the LVAD for a lung cancer patient who developed severe LV dysfunction during his treatment, his therapy. So his prognosis hopefully will improve very much with the LV implantation. So they are just out of the surgery. It's just a coincidence. But I fully agree with all that's been said here. Daratumumab actually is immunotherapy, by the way. It's anti-CD38. So, but we have so many options, and we need to open our mind and eyes and hearts to allow everything possible to our very high-risk population, who their major cause of mortality is cancer. So if, with open collaboration with oncologists and international collaboration, I think the field is just going to show its remarkable outcomes for our patients as well. And we should give them all the chance we can. It's exploring a new field, but this is why we are doing this webinar, and this is why we are collaborating on a daily basis. And this is the wonderful and the most exciting thing of our of what we do daily.
That's great. I think we have time for one more question. I saw Roberta had her hand up. I'll just put it down. Roberta, did you have a question? If not, we can go to one of the Q&A ones down here. No. Okay. There's a question from, I'm not sure who, sorry, the name's Swethika, but they're asking, any thoughts on decreasing the required surveillance time after cancer treatment prior to heart transplant? For example, in low-risk cancers, do you actually have to wait or not?
I think shameless pitch for some of the societal documents that provide guidance. Recently, ISHLT has had some, great work done in relation to various cancers and the risks for transplant. I think my general sense when going around the country is people are pushing the envelope with cancer because the treatments are so good. So what was once, in my generation, you have to wait 5 years for certain malignancies. I think the reality is people are changing their practice, and I think we'll see more societal opinion regarding this in consensus documents. Certainly, prostate cancer as an example of a highly treatable disease. When I think about the people that we're now offering either surgical advanced heart failure therapy, an LVAD, or a transplant, there has been such wonderful disruption in that area. Still need some guidance in regards to hematologic malignancies. I think there's a pretty significant signal about disease recurrence based on UNOS data. So I do worry a little bit about that. But as all of the panelists and speakers have highlighted, the field is moving in a very favorable direction, and we really do learn from each other in regards to this. And I think opportunities to collect this data in registry formats or platforms will be essential so that we can learn from each other.
I cannot agree more with Farouk. Just the recent ISHLT guidance for candidates for heart transplant. There is a special sections discussing all kinds of cancers and hematology to allow with all the updated data, and this is really an exciting field.
And I think it's important to remember that there are, I was also going to say that highlight those recent changes in the ISHLT guidelines, which are great for all of those of us who came up in the 5-year rule era, right? But I think it's important to remember that there are some cancers that are really immunologically mediated, and hematologic cancers for the most part fall into that, and so those are going to be the highest risk to immunosuppress someone. But there are others, and Farouk, you mentioned prostate cancer, where there's really no interaction between the immune system and prostate cancer. Prostate cancer we know exists in 70% of 70-year-old men and 80% of 80-year-old men, and so this is something that I think many programs are comfortable transplanting in a low-risk prostate cancer patient and just monitoring, right? So yeah, there's such I'm really excited that the recent guidelines sort of capture this varying risk associated with malignancies. They do not all fall into one bucket, and I'm excited to see how that continues to evolve as others have highlighted, our cancer therapies continue to evolve.
Okay, well, we're at 10:57, so I think I feel like the time flew by just because with both of these talks and these discussions were so engaging. Thank you so much again to Yael and Farouk for speaking, and for Darini and Margot for joining us for these panel discussions, and for all our attendees. Hopefully you guys all have a great rest of the day. Take care, everyone. Thank you.
Thank you.
Bye-bye.